Hi everybody, this is Rhys Barber from Audiology Associates. Thank you very much for watching our earwax removal video today. If you've never come across our channel before, we post new earwax removal videos every Monday, Wednesday and Friday, so please consider subscribing. So what you're going to see in our video today is one patient that's come through feeling very blocked up, especially on the right hand side, and some irritation on the left. Now this patient does have a little bit of ear, nose and throat history. They had a perforation when they were very young, and that perforation was surgically repaired, which is known as a tympanoplasty. So that was carried out on the right hand side, but patient today's come through feeling really blocked up. So without further ado, we'll go straight into the video. So if I just click that button there we go. So what you can see here, when we look inside this ear, the first thing you'll notice, the wax is very dark, so very old. The second thing you'll notice is that the wax itself has a really deep depression right in the center of it. Now that depression is because this patient has been using Q-tips in their ear canals. Now what you can see has happened here is the wax at some point was probably quite soft. And then when they've pushed the Q-tip into the center of it, so if you imagine this is your wax, the Q-tip goes in and the wax does that around the Q-tip. So it spread it and stuck it to all canal walls and caused this deep depression in the center, which is very, very deep in the ear canal. Now the difficulty we have here is that when we're trying to remove this type of wax, if you held the suction tube in the center of the wax here, the sides which are dried onto the canal walls are going to hold that in, so you won't get the suction grip to be able to pull that out. But what you can see I'm doing here is just slowly working around the outside edge, looking for any gap or any bit of play, if you like, in the wax, so we can lift those edge pieces off the canal first and then very slowly sort of peel those back so we can take this center section away. But as you can see, it's really, really difficult to find a loose edge around the outside edge of this wax. This patient's done such a good job of pressing this against the canal and allowing it to dry there that we've had this really sort of hardened up plate. This is one continuous piece of wax you can see here that's just really firmly wedged into that canal. So I'm using the fine end here, trying to stay just above the skin. So using imagine this is the end of the fine end here, just working very, very slowly across the edge, just trying to lift on the edge there and lift any pieces up like this. There's a lot of dry skin in here and I'm probing all around the outside edge to try and find a weak spot, but it's just so firmly hardened up in there. And even using the standard size ulnar tube, which as you can see here, because of that dome, that sort of depressed section in the center here, when you're trying to get a suction grip, you can't get the grip, the air escapes through the side, so you can't get that really good kind of seal that you need to be able to get the pressure to be able to pull this through. It's a really, really difficult one to do, this one. So I'm opting to use the Jobson horn here. It's deep and we've got to be really careful. I'm just trying to break an edge. If I can just nip a little bit off the edge there, as we're doing, you can see it just coming away there just at the bottom edge. It will help me to lift this section here and just be able to get behind. We've got a kind of a blunter edge, if you like, which is going to be probably a little bit thicker than this tapered edge we have at the moment. But you can see even with the Jobson horn, trying to find an edge to work with that doesn't push this depressed section further in is proving difficult to do. So I'm just nipping a couple of these little edges off. And now I'm using the Jobson horn slightly differently. I'm trying to push against that thin edge of the wax and lift off the canal to try and get a little bit of purchase then with the suction or with crocodile forceps if we're lucky. Okay, so back in with the standard size ulnar tube here. You can see that as we lift here, look at the difference, that section there. Look how wet that is. Now that's usually a little bit disconcerting, because if you see this sort of really dry wax like this and this very wet liquid type wax underneath, that would indicate to me that there is fluid trapped behind this wax. Okay, now given this patient's history of eardrum repair and tympanoplasty, you always wonder what's going on behind here, especially the Q-tip's been pushed in that deep. So we've managed to lift the corner off now, so we're just going to slow this down in a second because we've got a nice leading edge to work with there. We're just going to very, very gently hold onto it here with the forceps and just pull Do you see that whole thing slide away from that section? You can see how it was all held together, one big piece of wax here. It's very dry and brittle. Look at the color difference in the waxes coming out there. Where the forceps are at the top is really dark, a much lighter material. That shows me that it's that kind of wetter, more sludgy sort of liquid wax behind. So there's got to be something going on behind this. There we are. That's all coming away. So that whole section came out in one. You can see the color difference a little bit more clearly there as we kind of focus in on it. Well, if you are enjoying the video, guys, then please give me a thumbs up. Drop us a like. And like I said before, if you're not subscribed already, please subscribe. Look what we can see now. You can see that we've got this there's remnants of it here on the outside. Look how liquid that wax is. So this must be getting moisture from somewhere. There must be a discharge in this here somewhere. Now we're just going to take away this section to the right-hand side. Canal's a little bit on the narrow side, so difficult. I mean, this is the fine end you can see here, so it gives you some appreciation as to how big that canal is. But as you're kind of there, did you see that liquid coming away there from the base of the eardrum then? That's where the discharge is coming from. Now, based on this lady's history of perforation to the eardrum and an eardrum repair, I think what we have here, looking at this liquid that's coming away, is discharge from the middle ear space. So I think we've got another perforation here. And you can see that white circular section deeper into the bottom left-hand corner of the canal there. That's the bottom of the eardrum. As we suction here, we're just coming a little bit closer. Look at the liquid that gets discharged. There we are. There you go. So you can see we've got this perforation. It just looks like a recess, but if it wasn't as wet, but that is a perforation to the bottom of the eardrum there. So what's happening is that the fluid that we produce in the middle ear space is actually discharging through that hole in the eardrum, and there's been soaking the back of this wax, which has caused this really kind of slushy consistency there. So this patient, it's unclear as to whether by using the Q-tip they've actually reperforated the eardrum, or whether this is just something that opened up again that no one's really spotted before. I'm not sure whether I've just played the same bit twice. I may have done. I apologize if I did, sorry. But you can see there that hole is deeper. I think I did. I think I went back and re-edited the same bit twice, sorry. But you can get a second look at it anyway. So you can see you've got that hole just at the base there. We're just going to tidy up this little bit of kind of wet skin material here. With this discharge that comes out of the ear, it's not infection, it's just like a very thin watery discharge, but it can cause some irritation in the canal as this dries up. It causes a lot of itching, and the ear canal can feel quite irritated as well. Just tidying up around the outside edge now. There we are. Okay, so just zoom this out so you can actually see that wet material. You can see the hole there a little bit more clearly when you kind of zoom it in there. So yeah, this patient does have another discharging perforation. So we've advised them to go back to the GP. They need to go back and see the ear, nose and throat consultant, especially if it's discharging like this a lot. Whether they would look at repairing it again with the scar tissue, I'm not so sure. What you can see here, this is the second ear, but look how the wax is looped. It's kind of spiraled down the canal. This is the twisting action, you see, of the Q-tip going in here. It's actually spread it and twisted it around. So it's very dry. So I'm going to concentrate on this top section because this is the closest to the outer part of the ear canal. Pull this down, which is what we're doing here. Look how stretchy this is. It's pulling that dry, dead skin with it underneath as well there, where it's all dried onto the canal. Now if we can get a grip on this section, we'll use the crocodile forceps again. I'm hoping that it's going to take the whole thing out in one big corkscrew. So as we pull this down now, you'll see it just peeling away from the left side, that rear section, the side closest to the eardrum there, coming away nicely now. There we are. You can actually see the loop, the curve of it there as we take it out of the ear canal as well. One dry, hard piece. You see the eardrum there as well. Looks a bit retracted. You can see where it's actually, you can see the hammer bone there quite prominently. And you've got that sort of section to the right-hand side of the eardrum there, which has a little bit more flexibility to it, has actually been drawn in just a little bit more. We'll take another look at that eardrum now so you can get a good look at it. There we are. we were talking about the tympanoplasty and whether that would be another option for this patient. That would be the ear, nose and throat surgeon's call really on that one. They always weigh up, the risk of leaving more scar tissue behind against how well behaved that is, how much of an effect that is having on the hearing as well. So have another good look at this eardrum. So you can see there the hammer bone, you can see everything pulled quite tight around that. You can really clearly make that out there. And then you've got this section here to the right hand side where you've got that more flexible part of the eardrum, and it's drawn into the space behind. So yeah, quite retracted on that side. So this is what we removed. So the piece on the left hand side there, so up to about 3/4 centimeter, that piece there is the first section we took away from the first ear, and then the second piece there, the piece to the right hand side, is that corkscrew effect piece that we had taken away from the from the second ear as well. Lovely. So let's go back to my view. There we are. So what you can see from that is you can see why we advocate not using Q-tips, okay? When you see things like that where you've got this real indentation into the wax, you can sometimes push that wax further and you can cause more problems by using the Q-tip. It dries the wax out, it compresses it against the canal wall, and in this case it had pushed it very, very deep. In extreme cases, I'm not saying this happens all the time, but in extreme cases you can end up perforating your eardrum in some instances as well. Well, I hope you guys found that interesting. It's Wednesday today, so I shall see you again on Friday. Drop some questions. If you've got questions, by all means drop them in the comment section below. I'm still trying to keep up with the comments. I apologize if I miss any, but drop me a comment into this one as well, and I'll reply to as many as I possibly can. As always, guys, take care of yourselves, take care of one another, and look after yourselves. I shall see you on Friday.